common foreign body in a child is a peanut. So one should be very careful when giving a full peanut to a child. A patient will come, the mother may not be knowing the history. The patient will just complaining of some chest pain, shortness of breath or something, he will go blue. Mother may not give the history whatever is happening. And when we see a chest x-ray, we see one lung fill is more black as compared to the white other lung fill.
Good
Good
evening,
evening.
everyone. I am Dr. Devashish Roy, currently working as an intern in Government Doon Medical College, Dehradun. And today, as our guest, we have Dr. Ruchismita Ray, and she is working from West Bengal. So today we will be having a discussion about emergency X-ray, and she will guide us further along in this discussion.
Good evening, everyone. Today, I would like to talk on very important topic: emergency X-rays. First, to give a brief. Now, these days, X-rays don't carry as much value as it used to carry previously. But still, there are places where X-rays can never extend its place. It has its place always. It's like in emergency X-rays. Whenever patient comes in an emergency department, usually the first investigation, if it's especially if it's a trauma and few other cases which I will be discussing, X-rays are the most easily available modality available in most places. So what I have done, I have divided the whole emergency department into body parts, according to body parts. So today I will be talking about the chest, abdomen, and the upper limbs. First of all, I would like to take my reference that I have most of the images are taken from this emergency accident and emergency radiology book, Nigel, Ravi, Lawrence Berman, Simon Molde, Gerald de Vesey. This is an important book for us, so I just thought I should give it reference. So first of all, I will be talking about chest. So, day and night, we are looking at the chest x rays, and I would like to emphasize the normal anatomy of the chest x ray. I won't go into the details, but whenever we see a chest x ray, all the density, most of the densities which we see, is mostly due to the vessels, the normal interstitium of the lung, the lymphatic channels, the normal bronchial valves don't give any shadows. So, whatever we see here, as we can see, this is the normal chest ray, this is the heart, this is the lung, diaphragm, this is the abdominal part, this is the bony part. So all this tiny vessel-like structures is all due to vessels. So whenever we are looking at any pathology, especially the lung pathology, it appears as increased density. That means it appears more white. Well, there are other pathologies which appears more dark, but for the time being, I will be talking about only the denser lesions. So whenever we see chest X-ray, we will briefly have a look of the lung parenchyma, the cardiac shadow. There is a rule that the cardiac shadow should be less than 50% of the whole thickness of the lung parenchyma at its basal parts. So we call this CTR, cardiothoracic ratio should be less than 50%. This is the hyla. This is the place where the pulmonary arteries and pulmonary veins go out of the cardiac structures into the lung parenchyma. So it appears like these two widely separated fingers. This is the hyla, and this is the lung parenchyma. So whenever there are some tricky parts in the lung parenchyma, tricky in the sense that we may miss pathologies if they happen to arise in these places. One of them is this apex. This is the apex, which is partially obscured by these clavicles, and this is the hilar portion. These are like obscured by the hilar vessels. If any pathology is there behind the cardiac shadow, it also happens to obscure. And these are the places around the diaphragm where the lung pathologies are obscured. So we have to be more careful so that we don't miss these areas. So whenever in the emergency department, I have covered topic according to this. This is the most common things which come to the emergency department. I have omitted out the traumatic cases. I have taken the traumas separately. So these are the lung pathology which I will be talking about. First, the pneumonia. So pneumonia is any accumulation of fluid within the lung parenchyma, which usually signifies infection. Most of the patient will come to the emergency department with shortness of breath, fever. We will order one chest X-ray, and we will see something hazy in the lung. So how do we come to a conclusion? So very important sign is the silhouette sign. Now, what is the silhouette sign? It is like studying a structure against a contrasting background. Like when we see a sunset, so we see a black structure. When we stand in front of it, we say that the silhouette is like a silhouette of a tree or something like that. So in radiology also, when we study, the heart appears bright against the lung parenchyma, which is like dark or black. So we have very sharp margin of the cardiac structure. So when we do say that silhouette sign is lost, when there is some pathology of fluid density pattern which happens to be in contact with the heart, so we have hazy margin of the heart. The heart margin becomes hazy, and we see that the silhouette of the left border is lost. So the border is not very clear. So what is the conclusion? That they have fluid density against the cardiac margin. So we have, if we know the anatomy, we have clues how to go to which lobe of the lung is affected. If the right heart border is affected, as in this case, it means that the middle lobe is affected. If the left heart border is affected, as is in this case, it means the left upper lobe is infected. If the left dome is hazy, like in this case, this is the diaphragm, and this is some density which is obscuring the diaphragm, that signifies that left lower lobe is infected. And in this case, the right lobe is hazy, and it signifies right lower lobe is affected. So this is the silhouette sign for you. Also, we can take the lateral images. I have not gone into great details studying about the anatomy of how to define the upper and lower lobes. Otherwise, it would have been vast. I am just taking, if a person who is working in emergency gets an X-ray, they should be able to study just with the minimum things. So this is a normal lateral X-ray. We should follow the rule. Then as we go down, the upper vertebrae are more white, and as we go down, the lower vertebrae should become more and more dark. See, this is the normal thing, because in lower part of the lungs are expanded, more volume of lungs are there, so they are more black. But in this case, as we go down, we can see these vertebrae are appearing more white as compared to the upper vertebrae. And this signifies that there is some abnormality in the lower lung lobes, which may signify pneumonia or any other pathology. I'm talking about pneumonia in this case. So in this case, it's like hazy, it could be a pneumonia. Very important thing is the pneumothorax. I'm not talking about trauma right now, but most of the time, the cause of pneumothorax is trauma. But other causes of pneumothorax could be iatrogenic, when we insert any drainage tube, or it could be spontaneous also, when a person with asthma is having lots of shortness of breath, or a COPD patient which can have a spontaneous rupture of bulla. So pneumothorax is a medical emergency. Small pneumothorax can resolve by itself, but if the pneumothorax keeps on expanding, it compromises the rest of the remaining lung fields. So we should be very careful when we are reporting pneumothorax. Pneumothorax cannot be missed. So how we can see? It's very subtle. This is a fine visceral pleura which is seen as a thin line, very subtle, and we can see no vessels distal to the distal to the pleura. Here also we can see a subtle line which runs parallel to the chest wall, and we can see no vessels beyond this thing. So we have to pick up this thing. If it is a gross pneumothorax, it can be readily picked up, but we have to be very careful to pick up small pneumothorax, like newly developed pneumothorax. Most of the times, the patient who are in trauma or having just developed pneumothorax are like too ill to stand up. In them, usually the x-rays are taken in lying down position, and in that case, the air in the chest wall is present in the non-dependent part. So it's like anterior pneumothorax. So when we take an x-ray, we can see the air is deposited is here in the lower part, and they appear as a lucency. You can get a well-defined margin, as we see when the patient is standing, but when the patient is supine, we can see an increased lucency, means more black in the dependent part of the lung field. So it's not always a definite conclusion. We always have to clinically correlate. So if a trauma patient comes with shortness of breath and we see a similar picture, we can conclude that the patient may be having pneumothorax, and we may order further investigations like CT, as the modality is available in the hospital. So next is the left ventricular failure. Again, the patient comes to the emergency department with lots of shortness of breath, and we see an enlarged heart. So how can we make out that the heart is enlarged? Like I have shown you the previous cases where the heart border was smaller. Here we can see that, it's not always necessary to measure it. We can just have an eyeballing that here the cardiac margin, and this is the width of the lung from the inner border of the bone to the inner border of the bone, inner cortex. So the lung part only, and this is the maximum thickness part of the heart. This should be less than 50%. If it is increased, we can say an enlarged heart. But Not necessary this is always an enlarged heart. A person, if it's not inhaling properly, with not proper inhalation, the heart may appear bigger. Also, when a patient comes in emergency department and is too ill to stand up, the images are taken AP, that is means anterior to posterior, in a lying down position. In that case also the cardiac shadow may appear big, so we have to careful before claiming that it's an enlarged heart. Then we see septal lines. These are the thin septal line which is like the fluid going in between the interstitial interlobular septum. These septal lines are seen in the lower lobes, and they appear perpendicular to the pleura. And also we can see pleural effusion, bilateral pleural effusion. As and when the left ventricular failure increases, it has more and more fluid within the lung parenchyma. Here we can see the interstitial edema, that means it's more fluid within the interstitium of the lung parenchyma. And as it goes increases, edema also goes into the alveolar, and we can see fluffy nodular opacities which we call as alveolar edema. So all this picture together, we come to the conclusion the patient is having left ventricular failure. Severe asthmatic attack. So a patient when comes to this to the clinic, he must have been a already diagnosed case of asthma with having a severe attack. But why do we take X-rays? To know for if there is any complications because of the asthmatic attack. So in this case, what are the complications we are expecting in case of asthma? First of all, a lobar collapse. So this is all white. So why is this not consolidation? Because there is a volume loss. I have not gone in details describing the fissures which the lung have, but this fissure is raised up, or there is a lung volume loss. So, and also the patient is asthmatic. So we there's a collapse of right upper lung lobe. We can have pneumothorax. We can see a thin line parallel to the chest wall running like this, and we see no vessels beyond this. So this is a pneumothorax. Also, another deadly complication is pneumomediastinum. That means air goes within the mediastinum, and we can see a thin pram-like appearance here within the mediastinum. So this is pneumomediastinum. Pleural effusion is very common. We all know how to see pleural effusion, but still, to complete it, uh, chest X-rays are able to capture as low as 200 to 300 ml of pleural effusion. Larger effusion, we can see, and this is the meniscus sign. Meniscus sign is like cup-like appearance, like blunting of the CP angle, claustrophrenic angle. When the effusion increases, we can see like this. It is like about 1 to 2 liters, and with very large effusion, the whole lung field can be opacified, and we call a white outer lung field. A large effusion can push the mediastinum to the other side. Also, we can have effusions around the diaphragm, and we can also have effusion within the fissures, which is we call it encysted effusion. And this is also a linear pattern of effusion. So all these are example. This is a small effusion, this is small effusion, this is called meniscus line. Here also there is a larger effusion, about 1 to 2 liters. And what else can we see in this image? We can see an enlarged heart, we can see interstitial edema and alveolar edema, suggesting left ventricular failure and effusion. Here there is a little bit, this line, this is going, this is insisted effusion. This is the oblique fissure which has fluid within it, and it appears like a streak like appearance. Also we can see a hazy blob like opacities, which is like effusion in the posterior aspect of the pleura. And here we can see a critically ill patient with lots of wires going around, and there is some central line, some Ryle's tubes, and too many tubes. So we can assume that the patient is lying on the bed, and when a lying patient with effusion, we can see the whole lung field is like opacified, like a whale like appearance. So it's like effusion going all along the dependent part of the chest, and it appears like a whale like appearance. So this is also pleural effusion for you. Inhaled foreign body is very important. All very common in a 2 to 3 year old child, toddler. A patient will come with no history, because when a patient is playing with any, most common foreign body in a child is a peanut. So it's very, one should be very careful when giving a full peanut to a child. A patient patient will come, the mother may not be knowing the history. The patient will just complaining of some chest pain, shortness of breath or something, he will go blue. Mother may not give the history whatever is happening. And when we see a chest x-ray, we see one lung field is more black as compared to the white other lung field. So how will we know that which lung field is the normal one? But if here we can see no vessels properly. So this is an hyperinflated lung fields. And the most common, so there should be a high level of suspicion in a child with hyperinflated one lung field. So it's most common is foreign body. The foreign body per se is not visible, but it requires instant intervention. So one should have a high clinical suspicion for such type of cases. I will now go to the abdomen. I have omitted out the trauma part, which is like vast in its own. So I have covered some of the upper limb trauma in later part of this presentation. Abdomen. So I have also covered few topics which are like very important to be covered. One is that suspected intestinal obstruction. A patient comes with a distended abdomen. So first thing which comes in your mind is to rule out obstruction. So these are like two patients. You can see like dilated bowel loops. Here also we can see dilated bowel loops. So first thing that will come in your mind is intestinal obstruction. So this is a small bowel obstruction and this is a large bowel obstruction. Now how to differentiate between small bowel obstruction and large bowel obstruction? Small bowel obstruction, the bowel loops are in the center of the abdomen, and we can see thin septations or lines which are going across in a small frequency. Here this is called as valvular connivents, which are like in complete across the complete thickness diameter of the colon, and they are thin, they are more frequent and in more frequency. Here these are called horse rays. These are thickers, and first of all this abdomen is in the periphery of the abdomen, and these are thickers. These do not run in complete thickness and they are not opposite to each other. So these are like horse rays. So this is a large bowel obstruction. Here we cannot see any bubble loop in the central. So that's because the ileocecal valve is competent. If it had been so that the ileocecal valve is not competent, then this obstruction we would have seen both the small bubbles as well as the large bubble. So one thing which I have not covered, I thought I will be including and forgot to include, is the Rigler sign, which is very important. This is a sign which we see the, I think, which this is like pneumoperitoneum, and we can see both side of the bowel wall. So this is called Rigler sign. You should know the sign name, Rigler sign. But this is suspected perforation. Suspected perforation, the most important sign is the air below diaphragm. Air, if we are taking standing images, we can see air accumulating below the diaphragm. This is the air below the diaphragm. But whenever a patient is coming, he's too sick or maybe less air is there, we can take a lateral decubitus position and we can see the air in the non-dependent portion, and this we can do in suspected perforation. Also, if a patient comes with abdominal pain, there are few things we should also keep in mind. First of all, plain and simple pneumonia. So when we are ordering a abdomen x-ray, it's like quite logical to take one chest x-ray also, because sometimes the pneumonic patch, as we can see here, they mimic as the chest abdominal pain. So it's logical to take one chest x-ray also. There are other causes of abdominal pain. One is this renal colic. This is a CT plate. There is one calculus here which is causing obstruction and upstream hold up and hydronephrosis. So this is a chest x-ray. I have not included the plain one. There was some subtle density in the pelvis, which was like whether it's calculus or not. So contrast was pushed and image was taken after 10-15 minutes, and we can easily see that there is a hold up proximal to this. But now this is a place where CT has much replaced that this investigation, because if we go to do IBP or we have to take multiple images, so it's better, it's more clear cut if we take one CT cut. But many of the CT are not available, so these are good enough. Very important topic, swallowed foreign bodies. So again, we have to take proper history. Why is the patient coming to us? So whenever there is foreign bodies, first of all we have to take both AP as well as lateral views. So if it is swallowed, most probably it will be in esophagus. But if this is a coin and it's round in shape, so we are seeing round shape in AP view. Had it been not gone to the esophagus but instead gone into trachea, we would have seen it like slit, like as we see it in lateral view, thin slit like. So if we see this image in AP view, this signifies the coin is in trachea and would require instant intervention. This is esophagus. We can see that it is seen as round, so okay, this is an esophagus, but still we need to take a lateral view. Why? Because there may be 2 points. Most of these inhaled swallowed foreign bodies are small children, and they won't give proper history whatever is happening, so we should have a high level of suspicion to handle such cases. Also, this is a image where we can partially see the coin. So it's very important that whenever a small child with suspected some problem, we should include the neck also, because many a times the foreign bodies, they are stuck in the esophagus high up in the neck, and if we do not take the neck portion, then we may just miss out the diagnosis. So it's important we take this. Another important thing is to differentiate between a coin and a button battery. So a button battery is, these are too many devices, too many toys which come up with batteries, round shaped batteries, and many a times children they just swallow the button battery and they won't give proper history whatever they have swallowed. So it's very important that we have a high degree of suspicion to differentiate between this coin and the button battery. If a coin, it is simply very round moon like thing, but in button battery we can see it's like a two disc like structures. There's a faint groove around it, some sort of hypodensity. So it's important that we differentiate between those two, because these batteries, they may just erode the mucosa and they need to be taken out instantly, otherwise they may cause harm to the mucosa. So it's important that we differentiate between these two. In adults, the foreign body is mostly the fish bones or other bones. So most of the times, if we are not, again, if we don't have high level of suspicion and we miss this fish bone, they may stay there and cause retropharyngeal abscess, which itself is like a difficult situation. So first of all, this is a thin subtle hyperdensity, means a white like thing, which is like fish bones. So we will just in brief know the anatomy of the lateral neck. So this is the hyoid bone. This is the hyoid bone, and then we should know the normal thickness of the soft tissue anterior to the cervical spine in order to pick up retropharyngeal abscess or other dangerous thing. Okay, so around C3, it should be normally less than 7 millimeter. This should be less than 7 millimeter. Is very important. This is in the values. And around C4 to C6, this should be normally around 22 millimeter. If this thickness is more than 22 millimeters, if it's bulging like that, we should have a suspicion from some pathology retropharyngeal. This is a fish bone. Also, how to differentiate between which bones? The fish bones, they generally get stuck in the upper oropharynx, and the chicken or the pork bones, they get stuck in the lower part. So it's not like that if it's fish bone we are not looking down and chicken bone we are not looking up. It's like just higher degree of suspicion. If we know the patient is saying that I have got difficulty in swelling after I was taking a fish, we will be more keen searching in the upper part and the chicken bone to the lower part. Also, if like this was the structure, this is some fish bone or something which was missed, or it was taken as normal calcification and was missed out, or it was ignored in the first x-rays. After a few days the patient came back again, and here it is now more displaced more vertically. It was like horizontal and it was not looking like a bone enough. And after a few days the patient came, it is more vertical now. The distance of the retropharyngeal space is now more than 22 millimeter, and also we can see subtle air pockets around, which suggest air pockets means abscess. So there is a retropharyngeal abscess. Now it becomes a medical emergency. We have to handle it instantly. Here also we can see a bone in the lower part of the bones, but not all white things can be foreign body, and vice versa also. There are lots of structures in and around the neck which calcify and looks like a foreign body, so it's important for us to know the other structures which can calcify. So here's the details. This is the style of the abdomen. xylohyoid ligament, which calcifies. This is the anterior spinal ligament calcification. This is the thyroid cartilage and cricoid cartilage and other things which can calcify. So it's very important that we have in-depth knowledge of all the calcifications. We should have a high level of suspicion and the type of foreign body to conclude to the to the any diagnosis. There are other foreign bodies which hold importance. One is magnet. A single magnet may not be that harmful, but if we're taking more than two magnets, it can cause obstruction, and it can just join these two bubbles and cause obstruction and too many things. It's also a denture. We should have a proper history. An elderly came with history of some obstruction, and there was a denture which was not obvious in the AP view, and it came more clear in the lateral view. The other foreign bodies which can be are bezoars. This can be like one is like a trichobezor, in which mostly seen in psychiatric patient women who have an habit of picking of hairs and having it, eating it, and otherwise phytobezor, patient who are having some abdominal surgery, they are not able to digest fibers, they can have phytobezors. They will look like some mixture of funny looking with air mixture and all. This foreign body is bezors. And other foreign bodies are there like hard plastic clips, which needs high level of suspicion to come to any conclusion.